It's now 6 o'clock Central African time. Good evening, ladies and gentlemen. My name is Omolemo Kitchin. I'm a pediatric pulmonologist in South Africa, Johannesburg, in Gauteng. I'll be chairing the session with Dr. Andreas Jung, who is a pediatric pulmonologist as well, and he's the head of division of pediatric pulmonology in Cantonal Hospital Winterthur and Children's University of Hospital in Zurich. And he established a multidisciplinary program for long COVID referrals in February 2021. We have two excellent speakers today, Dr. Caroline Kosterink-Brackel from Netherlands and Professor Pierre Goussard from Stellenbosch. Our topic for today is long COVID syndrome in children. So long COVID syndrome is described as persistence of symptoms after SARS-CoV-2 infection. It was first described in adults population, with more kids getting infected through different variants of the COVID-2 virus. The disease has now been described in children, especially in adolescents. Our two speakers are going to give us a perspective of the syndrome from both the high income and low income countries. Just a few housekeeping rules that each speaker will have 20 minutes each for the session, followed by 20 minutes of questions and answers. Please look down on the question and answer session below and can I ask the delegates to please put the questions there such that Andreas and I will coordinate and ask the questions. Andreas will subsequently introduce the second speaker. Without wasting any time, I'd like to introduce our first speaker. Is Professor Pierre Goussard. Pierre is a pediatric pulmonologist and head of Department of Pediatric Pulmonology at University of Stellenbosch in Cape Town. He is a very senior pediatric pulmonologist in the country. He's done a lot of collaborative work with ERS, especially with regards to bronchoscopy. He is come from a very beautiful province called Western Cape, Stellenbosch, where they make very good quality rotten grapes and turn them into very great quality wine. So without wasting time, Pierre will start the session.
Okay, thank you, Omolemo. Thank you for that very kind introduction. Omolemo likes visiting Cape Town for that product he was referring to. So I'm going to talk about basically our experience with long or COVID in children from a respiratory point of view, or probably the correct term is more protected respiratory symptoms after COVID. It's not moving. Perhaps you must move it if it works. Okay. So we all know that COVID in children are mostly a mild or asymptomatic, and most children have recovered from COVID in children without significant consequences. But we also know that there's limited data especially in sub-Saharan Africa and other and lower medium income countries. But we also know in these countries, they have a very high under 5 mortality rate for pneumonia. And we obviously have other comorbidities in this world, especially TB and HIV. So, I mean, this is the study what was done at our hospital by Marike van Zalm during the initial COVID outbreak, where they looked at the admissions of children with COVID positive. And basically in our results, 50% of hospitalization of children with COVID with less than 1 year of age, and a high percentage, 75% of these infants needed respiratory support. The mortality was low, like in most other countries in the world, but we did see more severe COVID-19 respiratory illness in young infants, and the long-term outcome is not known. This is one interesting study where they looked at outcome in compared high income to low income countries or middle income countries. And there may be a higher or larger impact of COVID-19 fatality in low and medium income countries compared to high income countries. So this is recent work that was done by Rika, and it was recently presented by Isabel de Randel at the WH meeting, where we looked at the children follow-up after 2 years of the initial COVID infection and compared COVID positive with COVID negative. And although ongoing, this patient cohort has been followed up after 1 year of age, after 1 year of the original infection. 20% of these COVID children still had upper airway obstruction, 60% of them coughed, 20% coughed and wheezed, and that continued. And now some of these infants have been followed up for 2 years, and 50% of them is still coughing, and 50% of them cough and wheeze currently. So I'm just going to talk about our experience, and I say it's a bit of a mixture of pattern. Because we work obviously in an academic hospital, we were exposed to children with severe disease, and obviously in a world where we still see a lot of HIV and TB related lung diseases. So I'm going to briefly refer to our TB and SARS-CoV experience, fatal pneumonia due to Omicron, some neurological findings, small airway disease, and chronic lung disease. So this is an interesting child, 2-year-old child that was admitted with lower respiratory tract infections. He was confirmed to be COVID positive. No other viruses was isolated. And 4 weeks later, the child presented with severe lower airway obstruction needing PICU admissions, and subsequently had 2 more admissions during for lower airway obstruction, and is actually still currently coming back with repeated episodes of lower airway obstruction. So this is the original X-ray that shows signs of pneumonia that would not be out of keeping with COVID. And subsequently, when he is admitted, he has large lung volumes with air trapping as seen on the X-ray. And in the follow-up CT scans, what was done, he had a bronchiolitis obliterans picture. So this is not something that has been reported, and it's difficult to find related cases. I tried to search literature, and there was basically only one case that was reported, but this case was actually not a child that was already established to have bronchiolitis obliterans and then subsequently developed COVID infection and was treated with remdesivir. Thank you. Okay, we can move on. Thank you. So this is our first case of TB and COVID infection. We just have load shedding here, so I hope everything is still working. So you can move on. So this is the first case we've described and reported, and the child presented with large airway obstruction and was identified to be COVID positive. And I'll get back to this patient later on. This is an interesting young baby that presented during the Omicron outbreak at the end of the previous year. And it was a 7-week-old infant that was admitted to the ICU needing respiratory support. He was a premature baby that received CPAP after birth, but not surfactant replacement. And he was SARS-CoV positive as identified on tracheal aspirate with no other viruses detected. So this child was ventilated because of a high oxygen index, needed high frequency ventilation, and developed progressively severe lung disease, developing air leaks and pneumonia and pulmonary interstitial emphysema. This is just a pattern where the child starts with the diffuse alveolar disease, typical of COVID, and then progress to severe air leak disease and ARDS. Okay, next. So at this start subsequently died, and at histology it's very interesting that this child had organizing pneumonia with the alveoli filled or basically obliterated by a lot of fibrinous tissue. There was chronic inflammatory cell infiltrates in interstitial spaces, and some of the alveoli still showed hyaline membrane disease. What the interesting part was there was subpleural hemorrhagic infarcts, lung infarcts, as well as focal thrombosis in the pulmonary arteries, undilated lymphatics, and there was also thrombus found in the right ventricle attached to the endocardial wall. So that was the first case of Omicron basically reported causing mortality in a young infant. And what interesting was the histological findings was very much what was seen in adults with some severe thrombotic infarcts, which suggests careful assessment of infants and children presenting with SARS-CoV and warrant further investigation. And probably these children should be monitored with D-dimers, and the question still remains if they should be put on anti-clot therapy. Okay, so that was a child that presented to us with neurological features. The child was 4 years old. We can move on. With right-sided convulsions. There was no history of previous neurological insult. The child was febrile, hypoxic, and depressed level of consciousness, was transferred to ICU and ventilated. And then the big child had no focal neurological signs or signs of raised intracranial pressure. And respiratory examination, child had reduced ventilation in both right and middle lobe. The CSF was normal except for a high lymphocyte counts. And subsequently X-rays, the child developed atelectasis of his right lower lobe and middle lobe. And his SARS-CoV PCR was indeterminate twice, but the IgG was positive. CT and MRI was normal. So this child was treated and with antibiotics, but in anti-TB drugs, but also given methylprednisolone as a pulse therapy and intravenous IVIG due to cover possible autoimmune encephalitis. The child was weaned was extubated from ventilation and put in high flow, but it actually needed re-intubation very quickly due to respiratory compromise and decreased level of consciousness. The child then developed complete collapse of his right lung, and bronchoscopy was done with a lot of secretions found in the lung that was removed. And then on the X-ray it was noted, and also on a chest ultrasound, that the patient had right upper lobe consolidation, but also very high right-sided hemidiaphragm. The child needed ventilation support for 9 more days, and during follow-up examinations, it was actually noted that child had also neurological involvement with right upper arm and shoulder weakness and lower motor nature. Repeated X-rays and ultrasounds prior to discharge on day 20 revealed still persistence of the right-sided hemidiaphragm paralysis, but that improved when the child was followed up at day 56 after initiation of disease. So this is the X-rays, and one can see it's difficult to see the right diaphragm is high because of the consolidation, but eventually as the consolidation disappears, one can see the right high diaphragm that eventually recovers. Thank you. So neurological involvement have been described in children. We can move on. Next. So there is case reports of phrenic nerve palsy, especially in adults associated with pneumonia. In a majority of these patients, actually, the phrenic nerve have recovered. And in adults, it's important to exclude phrenic nerve palsy in patients with long COVID suffering from prolonged dyspnea. In this patient, because of the neurological involvement of encephalitis with seizures and ipsilateral shoulder and upper limb weakness secondary to associated brachial plexus plati. We will think this is also a COVID-mediated disease. Okay, we can move on. And it has been peripheral nerve, just go back. Peripheral nerve manifestations have been reported with Guillain-Barré involvement and also unilateral vocal cord palsy. So although there's multiple mechanisms of neurological involvement by the virus, it's been postulated as either by direct neuroinvasion or immune-mediated pathogenesis. And in this patient, because the patient responded to pulse therapy and immunoglobulins, we think that this was an immune-mediated disease process. So what about TB? So it's very difficult to prove that TB is more complicated in SARS-CoV versus children that's not positive. So we took our 2 years data, over 1 year's data of 2020 during time we saw most COVID. And we just only looked at children that referred to us with complicated TB needing intervention and bronchoscopy. And the children that was COVID positive needed more endoscopic enucleations for airway obstruction. And these children also need more surgical intervention for decompression of lymph nodes. And the children that was COVID positive needed TB treatment for a longer time period versus the COVID negative patients. So I'm not going to go through all of this, but this is basically a summary of the patient. The interesting fact is on CT scan, they all had necrotizing lymph nodes. All of them had airway obstruction. Some of them, because of ongoing infection and disease, had FDG scans that showed ongoing inflammation. We did biomarkers that is a bit spread all over the place, but most of them had increased IL-10 levels present. And the interesting patient is the patient that actually had COVID before he had TB, and that patient had a very high TNF and a high INF levels that may be more demonstrating aggressive disease. So we're still looking at the outcome of these children. So this is an example of a child with TB with expansal pneumonia, and then 6 months later, he still got the ongoing disease, then the right upper lobe, and also severe airway obstruction. And this child actually, after 9 months, developed this neck mass, and that was actually a TB abscess that had developed. And in the FDG scan, one can see the activity sitting there anterior. And that child was still culture positive 9 months after initiation of treatment. Another example of extensive right-sided disease, and once again, the very necrotic lymph nodes we see on the CT scan. And the FDG scan showing ongoing inflammation. Okay, we're going to don't have to show much of this. This is the original patient that presented as the COVID positive patient. 9 months later, the child still had airway obstruction, and at that stage, the child actually needed endoscopic enucleation with a persistent ball valve effect of the right middle lobe and right lower lobe. Okay, thank you. Okay, we can skip this one. We can go to the next one. Okay, so this is the last TB case. This interesting one, this child had a large subparatracheal lymph nodes causing severe tracheal compression, needing surgery. And the interesting fact about this child is at surgery, we actually did the SARS-CoV on the TB lymph node, the necrotic lymph node that was removed during surgery, and that was still COVID positive months after the child was originally diagnosed with COVID. Thank you. Okay, so what about chronic lung disease? We're nearly done. This is an 11-week-old baby that was shown to have COVID pneumonia. Child was ventilated for 14 days and remained oxygen dependent. You can see it's got diffuse alveolar disease. At 28 days, he still got very much fibrotic type lung disease with a hyperinflation of his right lung. So then he has a CT scan, and the CT scan showed this multifocal ground glass opacification with a more selection for a subpleural distribution. And there's another one, 2-week-old baby. This one was group B strep, infected in the neonatal period. In hospital, actually became SARS-CoV positive, was ventilated for 4 weeks and remained oxygen dependent. Once again, we can see this continuation of lung disease with small lung volumes with fibrosis that's developing. And on a CT scan, once again, one see this multifocal consolidation, ground glass appearance, and volume loss of the left lung. And the last one was a 5-month-old baby admitted with severe pneumonia needing ventilation and high frequency. Just the child was COVID positive, but it was also expert positive. And once again, at 20 days, oxygen dependent, and the same radiological picture. And CT scan, we once again see this diffuse bilateral ground glass opacification with subpleural areas of consolidation. So basically, of all of these children were less than 6 months, they had severe pneumonia at presentation, bilateral involvement needing ventilation, also high frequency. They were oxygen dependent at 20 days. All of these CT scans demonstrated a severe bilateral ground glass opacification. There was 50% of these children, 2 of them actually died. The rest were treated with methylprednisolone as pulse therapy and subsequently survived. So in conclusion, most SARS infections in COVID in children is mild disease. Young infants who have risk factors for more severe disease. Severe disease due to SARS may have thrombotic infarcts and must have D-dimers done. Post-SARS-CoV bronchiolitis obliterans have not really been reported. And then we may see there may be an interaction between COVID and TB with an imbalance in the pro-inflammatory and the anti-inflammatory cytokine pathways, but this needs to be proven. This may lead to more aggressive and prolonged TB. Interesting for us that we actually were able to identify SARS in the mediastinal lymph nodes months after the original infection. And although rare, chronic lung disease to SARS-CoV can occur, especially in young infants. And basically, I can just perhaps say too, we currently have a 12-year-old girl that's been on a ventilator for a month now. She is IgG COVID positive, but PCR negative. She has been hypoxic for a couple of weeks before coming to the hospital, and she had a lung biopsy done today. And it shows extensive bronchiolitis, organizing pneumonia with no vasculitis. So we're currently investigating that this may also be COVID related. Thank you.
Thank you very much, Pierre, for this presentation. I think Pierre has shown us impressively that there is certainly in a number of kids acute COVID disease associated maybe with some underlying risk factors. I think some of them might occur mid or long-term symptoms, but the interesting finding also or experience is that we observe long-term symptoms after COVID infection, also in kids that have very few symptoms or non-symptoms at all. I think that is an open question that we should be discussing later on. And a specialist in this field I would like to introduce is Dr. Kosterink-Brackel from the Netherlands. Caroline is a pediatric lung specialist working in both Amsterdam University Medical Center and Tirgoy Medical Center in the Netherlands. Caroline is involved in several studies concerning pediatric post-COVID conditions. She focuses there on epidemiology, pathophysiology, and also the question of how can care be organized. And Caroline is a co-leader of the IP4C International Post-COVID Condition in Children Collaboration. And I believe, Caroline, you will tell us a little bit more about that in a few minutes. So we're looking for your talk. Thanks a lot.
Thank you, Andreas, for this great introduction. Can you hear me right?
Yes.
Yes, and you can see my slides as well.
Yes, we can.
Great, thank you. Okay, so thank you for this invitation to present here today. It's a good day to have this webinar because today the WHO made a statement about the frequency in which long COVID occurs in both adults and children, and the need to recognize this condition better, to share knowledge about it, and to make sure that we have services adequately equipped for all patients. So it's a good day to have this talk. First, my disclosures. I am participating in several studies in our hospital, and we have received some funding, but they have not influenced our science. So about today's presentations, I will talk about how we should think about taking care of patients with pediatric post-COVID condition. And you already noticed that I use the term pediatric post-COVID condition, which is actually the same as long COVID. And my talk will mainly be about organization of care and research priorities we should have. So first I will talk a bit about epidemiology, and I will show that about 2 to 5% of children with acute COVID-19 will suffer from post-COVID condition. And I also wanted to take this opportunity to show a patient perspective, because these patients seek care and guidance from their physicians, but sometimes they find out that there's a severe lack of knowledge. So then we need to organize care for these patients, and there have been clinics initiated globally, and we wanted to show how they organize their care, but they struggle with the absence of scientific substantiation and international guidelines, which leads to the topic of research priorities. So first about epidemiology. So in July 22, the WHO showed that about 70% of people have been globally affected at least once with SARS-CoV-2, and about 3.7% develop post-COVID conditions. And then I speak about adults, of which 15.1%, that's about 21 million adults, have persistent symptoms for more than 12 months. For children, there has not been a universally adapted of used definition yet, which I will talk about in a few slides. And what they did is that they measured the average disability rate, which is quite high. It's 0.21, and it's equivalent to complete hearing loss or severe traumatic brain injury. Underneath, we see, of course, the epidemiology of long COVID, and we see the big rise in January of this year when Omicron came. And this leads to the concern about the possible high rates in the patients with post-COVID condition. If you talk about epidemiology in children, the first problem is that all studies are difficult to compare. So when this is a nice overview, which is published recently, and it shows that there's a big difference in prevalence of post-COVID condition after acute COVID. And if you look into this review, you see that also that the time of measurement is quite different between studies. However, they state that about 25% of patients do suffer from long-term complaints, and that the most common symptoms are neuropsychiatric and in the field of cardiorespiratory symptoms. When you look at it in another way and you look at the prevalence of symptoms clusters, then this is a nice study which is performed by WHO and on the lead of Theo Voss, and they have searched for symptom clusters in different studies, and if you look at it that way, and then you see that about 2.8% of children and young people under the age of 20 have one or more of the 3 symptoms clusters of long COVID at 3 months after acute infection. And if you follow them up over time, you see that prevalence, fortunately, also decreases. If you then look into the effect this have on the daily life and years without having disease symptoms, you see that then they come on a number of 1.9 years, which is after epilepsy and autism spectrum disorders still quite high. This is another summary about epidemiological studies, which again shows the big difference in frequency in which long COVID symptoms have been reported, and which also shows the big importance of using control groups to investigate this. And I think that conclusion is the most important, namely that almost all studies have major limitations, including the lack of a clear case definition, variable follow-up times, and inclusion of children without confirmation of SARS-CoV-2 infection. So based on symptoms or family members with a positive SARS-CoV-2 result. And that a lot of these prevalence numbers are based on self or parent-reported symptoms without clinical assessments and have been reported without the absence of a control group. And then we always have to differentiate between post-COVID syndrome and which I call post-pandemic syndrome, because a lot of our youth is struggling with the effects of lockdown. So if we go into this definition, on the right you see several names used to describe long COVID or post-COVID condition, namely post-COVID syndrome, COVID long haulers, long COVID. And post-COVID condition is the term used for adults by the WHO. And the WHO definition for adults states that a patient suffers from post-COVID condition when it has a history of probably or confirmed SARS-CoV-2 infection 3 months from the onset of COVID-19, still suffers or is suffering from symptoms that last for at least 2 months, and that there's no alternative diagnosis. And these symptoms can occur from the onset of acute infection till these 3 months, or that they occurred later, and that they can fluctuate or relapse over time. In children, there's not been a uniformly used definition yet, although today there was a meeting organized by the WHO to discuss that, and we hope that it will be published in the next couple of weeks to months. So that's good news. However, there has been a group led by Professor Stevenson in the UK, which published a pediatric research definition, and they added to the WHO definitions the terms young people. They stated that for research groups, we need to speak about confirmed SARS-CoV-2 cases, and that these patients should have at least one persistent physical symptom. I started with several international colleagues how about we define pediatric post-COVID condition in our patient cohorts, and this table shows that these definitions have a very wide range. So some cohorts only use this definition for children with confirmed SARS-CoV-2, and in most of them, 50%, it was not specified. The time period between acute SARS-CoV-2 and the diagnosis of post-COVID condition was also very different. And some of them mentioned impact on everyday functioning, but not all. So if we look into epidemiology, there are a few research priorities, which we also discussed in our international collaboration, which is called IP4C, which I will go into later. And the research priorities concerning research about epidemiology is that we should first organize clinical case definition. And as I mentioned, that consensus meeting organized by the WHO was today, so that's good. We also need a core outcome set, which means that when we study post-COVID condition, that we use the same outcomes, so it's easier to compare studies and to share databases to expand our patient groups. So a few months ago, led by Professor Mamlet from London and Russia, a core outcome set for adults was published, and currently, he is in the process of a Delphi procedure to make one for children. And if you want to join, you can contact Dr. Nina Selanova, who is leading this together with Professor Mamlet. Then we need to standardize CRF, and ISARIC, which has taken a lead in this very early already in this pandemic, has made one to identify children with post-COVID syndrome. And for that, it's very helpful. However, it does not go into clinical details, for example, when pulmonary function test has been performed or what kind of therapy is being given. And that is an important field to study as well. So therefore, a tier 2 for clinical evaluation is currently in development and it's in the feedback phase. So now about organization of care. And first I wanted to show you a video of one of the parents of our patients. She has 2 children with pediatric post-COVID condition and is a neuropsychologist herself.
The symptoms seriously hinder the children in their daily activities, school life, social life, personal life. They are unable or can only potentially attend school and cannot participate in social activities like their peers can. General practitioners, pediatricians, and school are at loss. Parents are sent from pillar to post and feel unheard, unacknowledged in their concerns, and feel powerless. They only want one thing, their energetic, happy child back who is full of life. I would like to ask you, invest not only in research into the cause of post-COVID syndrome in children, but also in good guidelines so that doctors will recognize it. And there will be a uniform approach with guidance and treatment. Recognition and acknowledgement of the disease is important for many parents, including myself.
Okay, so this is, I think, a very good statement from this mother who is struggling with children who are suffering from post-COVID condition for more than 1 year now. And it's shared by many of other parents. So this is an overview of Long COVID Kids, patient representative organization, mainly consisting of parents and children living with long COVID. And they stated that we as healthcare should ask for more awareness about a post-COVID condition, that we should recognize physical symptoms, and also that there's a high burden in physical symptoms and mental health problems, and that that there's a large effect on the family of these children, that these children miss a lot of their education, and it's a challenge to get them at school, and that there's too much and too few knowledge and guidance from government and policymakers. So I won't get into this too much, but I think it's very important to mention that these patients are struggling. So we had the same experience in Amsterdam. So in December 2020, we got frequent referrals of patients with suspected pediatric post-COVID conditions, but we didn't know anything about this condition. And we started a pediatric post-COVID clinic organized in a tertiary hospital with a multidisciplinary team. But very soon found out that this was a large patient group and that we needed to distribute care across the country. So we made a national guideline based on our expert opinion. No studies were yet published about pathophysiology and diagnostics and therapy. So we searched for international knowledge and experience to share that, which led to the organization of IP4C and a study concerning the organization of care. So these countries have clinics which participated in these studies, and we investigated 10 care cohorts of patients with pediatric post-COVID condition, and we used 6 other research cohorts for the tables about definitions. So if we talk about the symptoms experienced in the patients in these cohorts, they're actually the same as we see in adults. So the main complaints are fatigue, headaches, concentration difficulties, post-exertional malaise and brain fog, but also chest pain and anxiety occur frequently. Most care cohorts were organized as a multidisciplinary team assessment, and only two patients were seen by a single specialist. All patients saw at first patients in the clinic, although virtual clinics were used later, and 2 cohorts admitted patients for evaluation in some cases. All of our cohorts originated in university hospitals, and one was also a general hospital. if we look at what kind of doctors were involved, mainly that were pediatric infectiologists and general pediatricians and pediatric lung specialists, accompanied by psychologists and physiotherapists and nurses. A lot of different diagnostic tests were performed in these hospitals, focusing on cardiac evaluation, pulmonary evaluation, and exercise testing, but also psychiatric and neurological evaluation. Not many tests were abnormal. Mainly spirometry was abnormal in about 20 to 25% of cases, with a wide range between the different cohorts. And exercise test was also abnormal in a high percentage of patients. If we look at the psychiatric evaluation, we see that depression, but also fatigue were, and neurocognitive functioning were frequently abnormal. Therapies used were mainly focused on mental health interventions, physiotherapy, and changes in the daily life programs. And that is what we still see now, although also other therapies were used, like integrative medicine, diet changes, and we still see a lot of new therapies coming up, which actually worries me because they are not scientifically substantiated, and well, I think we should really focus on our research priorities on which therapy is good. So you have different models of care in which you can see self-referral or physician referral to these clinics, and care is organized in both first care facilities to tertiary care facilities. Teams can consist of single care visits versus multidisciplinary teams, and you can choose either to locate care close to home, to central facilities in the country. Diagnostics are mainly focused on exclusion of differential diagnosis, and I really want to state the importance of that, because the definition is so broad, and so many patients have suffered from SARS-CoV-2 in the last couple of years. It's really easy to make this diagnosis without any biomarkers at this point. So, however, if you see these clinics, there are really a lot of patients with other underlying disease. And if we miss that, we miss a very important opportunity to improve their complaints. And therapeutics, they can be organized in the first line, but also in rehabilitation clinics. And we see that in a lot of countries, guidelines are developing to distribute care, mainly in the primary care organizations of that country, and only the very severe cases refer to tertiary care. In my country, we have family doctors who see children first, and they can refer to occupational therapists, physiotherapists, and psychologists. But if patients get more severe, or when it's needed to exclude the differential diagnosis in a more broader way, then we refer them to general pediatrician in the secondary care departments, mainly hospitals, and in some cases are referred to tertiary care. And we actually made a national plan for how we should do that. And in this plan, we state what is important in medical history, physical examination, and evaluation. And we are not the only country doing so. In our country, we have a step care approach. So in the first 4 weeks after acute infection, we actually comfort patients, say that a lot of patients don't suffer from post-COVID condition, but that's already important to adapt the lifestyle to the complaints the patient at that time has. When patients are there more than 4 weeks, we already start treatment by physiotherapists and occupational therapists. The important concept of pacing. So we learn the patient how to prevent to do too much, because we know that especially in post-COVID condition, this can be a problem in the rehabilitation process. And if symptoms occur for more than 12 weeks, we start credit activity training, and we start with the build up of their condition, but also their emotional and cognitive challenges. Only when children suffer for more than 6 months or are very severely affected. So one of my patients, for example, has not been able to get out of bed for about 10 weeks after acute COVID. So in this patient, I already started intensive therapy, of course, after 4 weeks and gradually built it up. And she's now very, very well recovered in a rehabilitation clinic. But only in those severe cases, we use the multidisciplinary approach and use also the care in pediatric rehabilitation clinics. Okay, so and what I want to stress out here is that when indicated, start psychology in an early stage, because these patients have already been through quite a lot. And in our opinion, this is really helpful in getting them over their, in getting them through this rehabilitation period. Treat comorbidity, keep up to date with scientific literature because that's changing a lot. Encourage inclusion in therapeutic trials if they are there in your country, and stay aware of the use of self-medication and alternative medicine as well, because they can hinder your patient and they can also help, and we need to gain more knowledge about these types of therapy. What I also wanted to show was an example from the NHS in London, which has done the same as we've done in the Netherlands. So they've built a very comprehensive chart about how to refer these patients, where care should be organized, and what the clinical pathway is depending on symptoms. And it's very well findable on internet and PubMed. And as we've done, they have a very nice overview about which symptoms you can't miss and what kind of treatment possibilities there are there. And as our guideline is in Dutch, I thought it would be nice to share this. However, these guidelines are now mainly based on our opinion of our experience in adults and about expert opinion about our experience in other post-viral diseases, and we need to gain more knowledge and especially to research what type of therapies are useful. So if I want to talk about research priorities in care, then I think it's very important to mention that we should not only look into pathophysiology, but also what that means for the diagnostics we can use to better understand the physical abnormalities and the neuropsychological abnormalities in patients experiencing post-COVID conditions. Fortunately, there are many pediatric studies on the way, and we are already learning from adults, and those results lead to new studies and also therapeutic studies. We discuss them in our IP4C meetings, but it's also very important to stay up to date with your literature. Then on therapy, there's a severe lack of studies. That's a real problem. And we as international communities to address that. And I'm glad that the WHO has made a statement about that today. Prevention is already well studied concerning acute SARS-CoV-2 infection, which is of course also a way to prevent the pediatric post-COVID condition. These research priorities are actually quite the same as stated by the WHO for post-COVID condition in adults. However, there are much more studies concerning therapy going on in adults than in children, and that is a lack of that is something we should address. Because that will lead to guidelines which we can use internationally and which we can also use to compare effectiveness of therapy again. So this is the end of my presentation for today. I want to thank you for listening, and of course this has not only been my work, but work of a lot of different people who I work with. And I want to stress out that everybody here is welcome to join IP4C. We have twice of meetings bi-monthly, so every 2 months in the evening, in which we discuss where our research fields should go to, but also what the main concerns of patients are. And next month will be about clotting and pediatric post-COVID condition and what this means for our diagnostic workup and therapy. So if you want to join, please contact us. And I will distribute these slides so you can contact us using this QR code. Thank you.
Thank you very much, Caroline, indeed, for this excellent presentation. I think you highlighted beautifully the complexity we have in post-COVID conditions, and also the open question we have, starting with a simple definition, a diagnostic approach, treatment, but also that there is light at the horizon. We have treatment options that we need now to investigate on. We have research activities. So I think we're a good way to better understand what we are talking about and what should we do with these individuals. So I'm happy to open the Q&A session now. We have around 10 more minutes to go. We have currently 18 questions in the Q&A field. You can still put some question in here. We will not be able to answer all of them now, but as I said before, there will be links provided to the both website of ERS and PATS, so you can have this question answered. So I'm just having a look at the questions, maybe starting with a question to Pierre. There was a question, how many COVID positive patients had also other viruses like RSV, rhinovirus, or developed this after the acute COVID infection? Is that, are these data available?
Mostly not, and especially not from the first part of the COVID pandemic. I think like in most places of the world, so very selective investigations was done. So most of the original studies, people didn't do other viral screens, and subsequently it have been done. And some of those data Marika van Zalm have and will published, but in the cases that we manage from a more severe disease, most of them we actually did look for other viruses, and the ones I showed in the ICU setup, those ones we actually didn't identify other viruses present. But I mean, and it's obviously a very important question is which is the specific pathogen, and the fact that it's still is COVID positive, that may not be the only pathogen. So the ones where we had severe disease and we were thought that there was specific involvement of COVID, we did look for other viruses, and in those ones we couldn't identify. But in a bigger or more ward-based treatment, virus studies was done, and that data have been published, but there was a significant number of other viruses also identified in those children, like we will see with most winter episodes, that we obviously do have multiple viruses present.
Thank you, Pierre. Another question for you, please, with a short answer. Are there severe cases still being seen despite vaccination in children?
Yeah, I saw that question, but remember, we don't vaccinate children. So children are not vaccinated in South Africa. We do obviously see much less cases currently. We do see the odd case, but no severe cases in the last couple of months. But children are not vaccinated currently in South Africa.
Okay. I would like to ask Caroline the same question. Do we have any evidence that vaccination can prevent long COVID or post-COVID conditions? Is there anything known in children on that?
To my knowledge, it's not. However, we do know that when you experience asymptomatic acute COVID or only with very mild complaints, that the occurrence of pediatric post-COVID conditions is much lower than in patients who, for example, have been admitted. I haven't shown these results today because of lack of time, but there have been some very nice studies about patients who have been admitted, and that occurrence of pediatric post-COVID is about 35 to 40%. However, only about 1 to 2% of children in our in Europe are admitted for acute COVID or MIS-C. So that's why I didn't present it. So in my opinion, yes, you can prevent a pediatric post-COVID condition because the chances are lower to get the more severe type of acute COVID infection.
Okay. Another question for you, Caroline. How do we differentiate deficits in scholastic functioning secondary to long COVID versus non-attendance of school during lockdowns and time of illnesses? Very important question, I believe.
Very
difficult.
Yeah, and very difficult. And that's one of the problems in all these different studies. My university is busy with that. So we investigated scholastic functioning in the whole population, which didn't have acute COVID. And then but were in a lockdown period. And then we investigated using exactly the same methods in acute COVID cases who tested positive or patients who have tested negative. And we're still waiting for those results. But this is one of the big problems currently, because of all these patients who are suffering from these symptoms. A lot do experience post-COVID condition, because if you see the difference between the negative and positive controls in the controlled epidemiological studies, there's definitely a larger group of positive patients who experience these symptoms. However, there's also a high number of children experience these problems in a negative control group. So yeah, important questions and difficult to answer.
The question is there any relationship with severity of acute COVID infection and long COVID? There's an addition, most children have asymptomatic infection. So is there increased risk of long COVID with symptomatic infections? So symptomatic infections and more severe infections. Can we say that?
That's difficult because the asymptomatic group, how do you, there are not many studies who have searched for serology results, for example, and then use follow-up. So all of these patients have been tested. And I don't know really if there's big difference between, if there are much studies about is asymptomatic or only mild disease. Do you know that, Andreas?
Sorry, say that again.
I find it hard to answer these questions because
yeah,
many studies.
Absolutely. I mean, our experience probably is limited in each center because it's still overall not a very common decision. So we have small case numbers, and I always try to figure out if there is some sort of relationship. But I also have patients sitting in my clinics who tell me I had a COVID because I was positive, but no symptoms and all, and now I suffer for months. So that is really a challenging question, I believe. Yeah. Okay, is that another question? Has recurrent wheezing often been seen in pediatric post-COVID conditions? I'm not sure, Pierre, if that is a question for you, maybe recurrent wheezing.
Yeah, except for specific cases, not really. I think the work of Marika, they have shown that there is a patient-reported or parent-reported wheezing, but surely we don't see in our clinical practice, we don't see frequent episodes of wheezing. COVID-related. Cough is more common than wheezing.
Another question is pointing on the fact that some children, and I also see that in my clinics, have recurrent episodes of COVID. So is there a risk factor for post-COVID syndrome when you have more recurrent infections, or is it maybe even a protective factor for post-COVID condition? Also interesting, but difficult, isn't it?
Yeah, questions, but difficult to answer. So there have been some study in adults about vaccination for acute for adults with post-COVID condition, and those results have been very. So for some patients that worked out fine, so they were quicker recovering from their post-COVID conditions. However, a few adults were actually getting more severe symptoms, and my experience in our clinic is the same. So a few do recover more quickly after they have a reinfection, but some also get again more severe symptoms. So they have been recovering, but get new infection, and then go back into their activities again. So difficult to answer, not many studies, but from experience, it can go two ways.
So we still need to learn a lot, and I'm looking forward to a follow-up seminar, maybe in a week's time, a year's time or so, to explore what have we learned in between. Before I close this webinar, I'm looking at my co-chair, Omolemo. Is there anything else you would like to address or ask to the speakers?
I think I've seen quite a lot of nice work that has been done by Caroline in the group. And I was just thinking for Pierre, is there a way that South Africa, especially with Africa and low middle income countries, can do a bit of collaborative work to give experience, especially in our patients who are actually vaccine naive with regards to this long COVID syndrome?
I mean, I look at Caroline's talk and the work they do and the ability they have to monitor and follow up patients. I mean, for us, that is mostly not possible and basically only happen in a research setting. So it would be wonderful to collaborate, and even if not physically, if you actually have the established protocols, how you can follow up these patients and monitor the data and put the information and finding in a database. Because one do have to realize the world is different for us on this side and that side. And our children obviously live in a different environment. So we say they cough after COVID, but one must remember nobody really follow up patients as these patients have been done post-COVID. So their normal environmental exposure, there's a lot of other reasons why these children will cough and have recurrent infections that may not be only COVID related. So it would be wonderful to collaborate. But I mean, we look with envy and see the ability that Caroline has shown to have to monitor these patients and follow them up and the dedicated care they give to these patients. And we, as you know, we struggle on this side of the world doing that sort of measurements and treatments.
And that's very understandable. But if I look at my country, we struggle as well, and we have much more possibilities because there are just too many. So we really have to differentiate what kind of care each type of patients have. In the meanwhile, taking care that all these children can find the type of care they need. So that is a struggle, and I really would welcome to work together in that. So one of the ways is by expanding our group in IP4C. There is a lack of people from South Africa, but also Africa in general, and it would be really great if people working in this field could collaborate with us in IP4C. So please, if you want to join, you can send an email to ip4c@amsterdamumc.nl. It's not only organized by Amsterdam, but also by Daniel Mamlet and the Nederlandse Center from Rome and from Louise Sigrid from ISARIC, and we all collaborate and work together with WHO. So please join us.
I think that is a fantastic last word, and I think that's really important. This research is needed to get a better understanding what is post-COVID condition and how could we deal with it, how could we help these individuals. So I want to thank you, Caroline, and you, Pierre, for your excellent presentations. I'd like to thank the PATS and the ERS to make this webinar possible and organize everything. I'd like to thank the participants, the audience, and before giving you a farewell and a good evening, I would like to indicate or highlight that there is a further joint webinar coming up in December by PATS and ERS, and this pediatric webinar is on TB and multi-drug resistance TB in children. And I think you will receive the information, further information on this in a bit. And for all those whose questions were not answered, again, all participants will a link to the websites. So all questions are answered after this webinar by the speakers. Thanks a lot to you all. Have a good evening and see you at the next webinar. Bye-bye.
Thank you, Andreas.
Cheers. Bye-bye.
Bye.